Welcome to the CodeCast Podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the CodeCast Podcast today. We are on episode 33. We're well into June. For those listeners that are new to the podcast, thank you for searching us out. We really appreciate the downloads. For our loyal listeners, we can't thank you enough. We are now number 1 on medical coding and billing search for iTunes, number 2 on Google Play, and I think we just hit number 2. We were number 3 last week on TuneIn. So it's very exciting for me. My producers are very excited about it as well. We work really hard to bring you quality product to you each week. So thank you again for listening in. Find me on social media. I'm on Twitter at TerryCoder1, and I'm also on Instagram at TerryandCA. So feel free to reach out and say hi on any of the media platforms that are out there. We really appreciate that. Before we dive into today's topic, CodeCast is brought to you by Advanced MD, spotlighting telemedicine as a solution that's proven to boost patient engagement and bring in new revenue streams for your practice. AdvancedMD.com. And Healthcare Executive. Healthcare Executives Network is the fastest growing community for healthcare executives and their trusted partners. healthcareexecutivesnetwork.org. Now, a couple things. Just wanted to let you know, this is like my 3rd or 4th try recording today. I feel like I have some background noise in the office space that I do share with a couple other people. So hopefully you're not hearing it. It's kind of driving me a little bit crazy, but it seems to have quieted down. So hopefully we'll still be able to get through it, and I won't want to throw my computer out the window. So anyway, we're glad that you're with us. And my topic is going to be something that I've really wanted to talk about, but I really wasn't sure how to put it together because I want to be sensitive to everybody when I talk about querying your physician. So I like to call this, don't be leery of the physician query. This is going to be 10 to 12 tips to really ensure that your queries work. And what that is an AHIMA, American Health Information Management Association, they also have an opinion on how to query a physician. And I think we agree that a query can be a powerful communication tool to clarify documentation in the health record and to achieve accurate code assignments. So querying has become a common communication and education tool for clinical documentation improvement. That would be CDI. Typically that's focused on ICD-10. And then also coding departments and billing, central billing offices, that's focused more on CPT and billing issues. So an effective query process can really aid the hospital's compliance with both billing and coding rules, but as far as providers and physicians, which I kind of go on the physician side of things, it can also serve as an educational tool for providers, also CDI professionals and our coding and billing professionals, which I really like to speak to, as well as the physicians. So how do you, as a coding professional, ensure that your queries are effective and compliant? And you also don't want to be afraid of a query. That's really where, I know some of you are a little bit, I don't want to say concerned, but maybe a little nervous to approach a physician if you haven't done it before. It'd be like getting up and trying to speak in front of a room if you're not a public speaker. You're not sure how the physician's going to engage, or maybe you have a couple of physicians in the group that, a lot of physicians, I think, get the perception that they're not really staff friendly, when really, don't take it personally. Doctors are going a mile a minute all day long, and they've got so many different things going on in their head when it comes to patients that it's not personal. It's not directed at you. It's directed at just trying to balance everything for them and really consider the patient with what they're doing. So first, before you query a physician, it's important to understand when to query, keeping that in mind that doctors obviously don't want to be told what they're doing wrong, but you need to communicate with them. You need to be able to do your job. So to be able to do that, we're going to look at a couple of guidelines. AHIMA that I mentioned earlier has some things that should be considered within the health record. I've added to this process as well, myself, not just as an educator and an auditor, but as an on-site consultant for many practices around the country. This is what I'm seeing when it comes to trying to engage the physician. And queries usually come in email form. So it could be in text form. I hope it's not too often that way. I like to see them more in email form so that you can get a written response back from the physician and share it also with management within your billing and coding office. So it is important, first of all, this is what should be considered. First, if there is a conflicting, imprecise, incomplete, ambiguous, or inconsistent documentation, obviously you're going to want to query them. Associated clinical indicators related to a specific condition, a diagnosis without an underlying validation clinically, an unclear POA, which is a present on admission. This is more for hospitals. One thing, if you're not an inpatient hospital coder, one thing you should know is that for inpatient DRGs, which are diagnosis-related groupings, it's why the patient is present. And what CMS needs is they need an indicator they call a POA indicator, usually in a general acute hospital care setting, but they need this to be able to push through the DRGs. So that's what that is. But basically, what I'm talking about here is just things that you just can't, they're confusing, there's just some ambiguity to it, and you're just not getting exact information that you need to keep going. So as experienced professionals that read healthcare record after healthcare record, sometimes it can be easy to fall into a trap of playing doctor. So I'm sure you've heard, I don't play one on TV, but many times we may see a connection that isn't documented, and this can mean that the information isn't as complete as it could be. This is a good reason to generate a query. And you have to be careful not to read into anything. So it's possible to read too far into the documentation and make connections that don't really exist. And you have to be careful about that, because when you look at it, when you've been auditing a physician for a long time, especially the same physician, you can tend to say, oh, well, what he or she meant to say, and you don't want to do that. And so before submitting a query, stop and consider the appropriateness. I wrote an article recently for ICD-10 Monitor about assumptive coding relating to the assumed causal relationship to certain diseases like heart disease and hypertension, carotid stenosis and stroke, even when the physician didn't link the relationship. So if there's an issue in the documentation for the patient that needs clarity and clarification, a physician query is necessary, and you shouldn't be afraid of it. So we're going to look at some examples. Some of these came from the Journal of AHIMA, and some of these also come from me because of what I've seen. So we just want to really make sure that we understand to write an effective query. This hopefully can help you. So number one would be queries are not the time to educate a physician about coding. So we should not include ICD-10 codes, details, or coding guidelines or rules that we follow unless the physician requests it as the reason for the query. So remember, the goal of the query is to make the record clearer, nothing more. We're not educating at this point. We're just asking the question. We're querying the physician. Number two is use a consistent, compliant format. So often introductions are skipped in a query, but you should use the introduction to explain why the patient was being seen or admitted, then present the clinical picture, quote the documentation in question, ask the question, and then provide certain response options. Doctors really actually like it if you provide them a couple of response options. Otherwise, they'll just say, go back and look, and that's not always helpful. So you want to give them a couple of response options to show that this is what you're thinking, or are they thinking this? And so, especially if you're a coder or biller and don't have a clinical background. So many of you to listen to this know I have the clinical background, and so I have a little bit, I don't want to call it an edge, just maybe a little bit of insight there. And so you just want to make sure that if you don't have that, you're really giving coding responses. Okay, so just keep that clear. That way you can have a good dialogue with the physician. Have clear titles. So titles of queries should be generic. Don't ask questions or offer options to in the title. So for example, a good title query would be CHF type, that's congestive heart failure, as opposed to CHF systolic or diastolic. You don't want to start diagnosing a patient. You want to basically put that in the body of your report if that's or of your query if that's where you're going with that. Number four is make sure your question is clear. Be direct in what you are asking without being leading. Make queries simple and to the point without too much clutter. One thing I hate is filler. I just don't like filler at all. And so you want to make sure that you just get to the heart of it. What are you trying to say? Offer response options. So never tell the physician what to write, no matter how clear the clinical picture appears to be. Be sure to ask clear questions and always provide the physicians with multiple answer options. And always include an out, such as unable to be determined. this will aid in the query being compliant because maybe you can't determine it from the record that you were given. Number 6 is be professional. So this can be a matter of taste or communication style, but it's recommended, and I'm going to recommend this, to avoid personal pronouns like I or we, or be more formal and less personal. Okay, and also do not get in the doctor's face about you can't do this. The doctors, it's their practice. They can do whatever they want. Obviously, what that comes with are the ramifications, but you're just querying. You're asking a question. You're not accusing or anything like that. So you want to make sure that your communication style is compatible with the person or the physician or provider that you are engaging or trying to get this query from. So we've gone through 6 of them, and let me just recap. Queries are not the time to educate. Use a consistent, compliant format. Have clear titles in your queries in the subject line. Make sure your question is clear. Offer response options, and then be professional. Okay, so that's the biggest thing right there. Now, before we go on to the next 6, I want to stop and also thank our sponsor, Worldwide Medical Staffing. They're new to us. Contracts in top federal and state medical facilities across the U.S. www.medical.com. Okay, so we want to look at number 7. Be concise. If your queries get too wordy and cluttered, they become confusing, and you may not get the information you need from the physician. Usually, the physicians stop reading after 3 sentences. So, I mean, they just really what are you trying to say? So, try to be concise in your what you ask. Put the question last. So only ask one question in the query and make it the last statement before providing the response options. So you're giving the information, and then you're basically saying, okay, here's the question from that. And remember, you're always going to have to cut and paste what you see. When I do audits and then I educate physicians who don't pass these audits, the first thing they say is, can I see the record? Because they want to be reminded what they said. I can't tell you how many times I'll get a provider, mid-level, or a physician is saying, well, I don't think I said that, and then we go back to the record and they're like, wow, I did say that, or that's, now with EMR, that is how it was populated. So sometimes you'll get from a physician saying, well, that actually shouldn't have come through, or that's not what I meant for this patient. So make sure you put the question last after you've built your case, and again, but still be concise in that. Avoid yes or no questions, and that's a big one. Writing a query in such a way that a physician can just say yes or no will leave you asking yourself, okay, yes, what? It's kind of like an HPI or a chief complaint in an E&M record that says patient here for follow-up. Follow-up for what? So was the condition ruled out? Does the patient still have the condition? Again, always offer response options. And then they can always write something in as well, or elaborate, or expand on that response, but there should be some options there. Number 10, quote the medical record word for word. Okay, you don't want to add any filler, and you want to be accurate. So when you quote word for word what was stated in the documentation that was in question, you avoid the risk of introducing information that was never there to begin with, which leads to the next tip. And that's actually the big one. Number 10 is huge. But the next tip is never introduce new information. Okay, so in a query, you should not ask a direct question about something that was never diagnosed without giving the physician an open choice. So again, if you're not clinical especially, you want to stay away from that. I saw recently, I was doing some training at a practice in Chicago, and they were saying, well, what I try to do is I try to let the physician know, well, this sounds like this and this sounds like this diagnosis. I'm like, no, you can't do that. And I go, are you a nurse, or are you a clinician? She goes, no, I'm a coder. I was like, oh boy. So, I know that a lot of us that have been coding a long time, again, I'm 30 years in, I know that we tend to, because we've read so many records, audited so many records, and again, I have an RN background, so it's a little bit different, but when you take that coding piece and try to say that all of a sudden I'm a clinician, you're going to get yourself in trouble. So be careful with that. I know we have some mid-levels sometimes that think that they're not an extender and they think they're a physician. So we just have to be cautious with that. I appreciate the clinical information that you've been able to pick up as a coder and biller. Oh my gosh, it's hard to do your job without it. But we just have to be careful we're not reading into anything for the physician. And then last but not least, reread your query and ask yourself, should this be a query really be sent? Sometimes you just want to vent. And sometimes sending an email to vent, I do that sometimes. Is this query clear and concise? Does this query solicit an answer that I can code from? And if you answer no to any of these questions, rework your query, or don't send it at all. And also if you're getting upset about something or mad about something, that 24-hour rule you've heard about, you need to use it. Just take a step back, 24 hours, and then go ahead and say, okay, now I've got a clear head. Was it really that bad? Is it something I can work through, or can I go ahead and send it? Because anger comes out in emails, in text, in electronic communication. You don't know tone. So there's a lot to keep in mind when querying a physician. And you can also, I'm going to put some of this on my blog post on my website at terryfletcher.net so that you can kind of see, more tips and more areas where it can be impact on I-10 and where it can impact on CBT as well. But hopefully these tips will help you with your queries and make sure they're appropriate, effective, clear, and compliant. And then also, what tips do you have for creating physician queries? So send them to me. I'd love to hear how you're working through that and engaging with your physicians and what is working and what isn't working. I like to hear both ends of that spectrum. So always happy to hear from you. Then as always, we like to end with our coding question. So today I'm going to look at administrative claims a little bit, immunization, because I'm noticing practices as I'm getting more into allergy and immunization and things like that from a specialty perspective. I'm noticing that some of the coding isn't perfect because you're not really looking, some of the people who are coding these aren't really looking at the appropriateness of what's being done. And you have to be careful with that because there's two categories when it comes to administration of immunization. So it's either coding with counseling or without counseling. So there's a 90460 and 90461 add-on code, and that's administration of immunization through 18 years of age via any route of administration with counseling by a physician or other qualified healthcare professional, first or only component of each vaccine or toxoid administered, and then each additional, which is the add-on code. The thing you have to keep in mind is that is with counseling. So to report those codes, the provider must document patient age. These codes apply to patients age 18 or younger. And for patients older than 18 years, then you're going to go to a little bit of a different category. But you have to have a face-to-face counseling with the patient or family. Patients have questions about vaccines, and they recommend for their children. And the provider may spend a significant amount of time educating and counseling on these. The encounter documentation should detail the vaccines given and summarize patient risk, factors or concerns, and information shared with the patient or family. Now, I had a question, and this is kind of leading to this. It says, Terry, if the provider does not document a face-to-face counseling in the record, how do I code for an administration of immunization? I'm not sure how to do that. Well, at this point, you're now going to be turned to the 90471 codes to 90474 codes. These codes say immunization administration, and it also says one vaccine, but it doesn't say anything about counseling. So that's just the vaccination. Basically, when you're reporting this, it's just either oral or injected vaccination, and it's really without much counseling. It's, maybe there's just a quick talk about it, but it's not a documented encounter, if you will. It's really more about just the injection. And so to be able to code the higher level of service, you really have to make sure that you have that counseling documented. But a lot of times the provider really doesn't counsel the patient or family and just gives the components of the vaccine. And so if that's not done, then you want to make sure that you're not coding for that. But one of the couple of the vaccines that are really included or should have counseling included would be the HPV vaccine. Sometimes though, if you're getting an influenza shot, that's a little bit different. You're not going to see that. If you're dealing with tetanus a lot of times, or diphtheria, you're going to see a lot of discussion with that. Are they going to get a fever? Is there any side effects with the physicians and the family? So those kinds of things are important to make sure you know the difference there. And that would be our questions for today that we're going to end with. So I just want to finish up with my last sponsor today, and this is Women in Healthcare UK. Women in Healthcare is a community for healthcare professionals aiming to provide a platform for women within the healthcare sector. Since 2001, England, United Kingdom. So another thing for next week, I'm going to look at simple mistakes in the daily processes. And so you're going to see some coding mistakes, some things that aren't added. It seems like all I've been dealing with are these simple little errors on my Coding Corner service this last couple of weeks that could change the outcome of reimbursement. And so I just wanted to address a couple of those little things to make sure that we're not doing that and that you've got a heads up about it, because it could present a problem in your practice. So we're going to go ahead and conclude today. Want everybody to go out and make it a great day, and thank you again for listening. Talk to you next time on the CodeCast Podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter at TerryCoder1 or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.